And now for our next talk, we're very fortunate to have Carolyn Broderick with us, a Sydney-based sport and exercise medicine physician, associate professor in the School of Health Sciences at UNSW, and staff specialist in sports and exercise medicine in the Children's Hospital at Westmead, a medical director of the Australian Olympic team for Paris last year, and the chief medical officer at the tennis, which we're very lucky doesn't clash with this meeting, as we heard a few times already. And title of her talk, Managing Infectious Illness at Major Sporting Events. So please join me in welcoming Associate Professor Carolyn Broderick.
Thanks, Paul, and thanks for the organising committee for inviting me today. I'd also like to thank the traditional owners of the land on which we're meeting today and pay my respects to their elders past and present. I'd also like to recognise the incredible contribution that First Nations people make to sport in this country. We've had 66 known Indigenous Olympians, and we had 11 Indigenous Olympians at our Paris Olympic Games. Now, I put that photo up there because I reminded myself of the last time that I met Lou Irving, which was exactly 5 years ago nearly, when I opened the curtains of my hotel window at in Melbourne and saw this thick plume of smoke sitting over the Melbourne Park where we were about to start the qualifying event for the Australian Open. So I do what I always do in a tricky situation, I ring the expert. And so I rang Lou, and almost before I was dressed, he was down at the courts with his spirometer and lots of very wise advice. I was very grateful for that. And so then come the second week of the AO, I thought, oh, easy street, I can relax now, the heat's gone, the smoke's gone. And then, hang on, I'm just going to try and, oh, sorry, going the wrong way. Oh. Wait a minute, just which way do I go forward there? I should know that by now, I should have done that. Oh, there we go, thanks. Sorry. And so come the second week of the AO, that was when Melbourne recorded its first case of COVID. And in fact, the second week of the AO, we were due to host 1,000 people coming, or sponsors coming from China that were coming for our finals. So that was welcome to the 2021 and 2022 Australian Opens. And I'm not going to go through how we managed infectious illness in 2021 and 2022, because I think you probably read it on the front of the Herald Sun. And that's a period that brings back a bit of stress. So I thought what we'd do today is just focus on some practical things of what we did in Paris, really, to manage infectious illness in this sort of semi-post-COVID era. Paris was my fourth Olympic Games as a doctor, but my first as medical director, and I must say it was really my favourite. It was an incredible event. It was a harmonious team. It was a successful team. I don't think those two things are unrelated. And Paris was just the most spectacular backdrop for every event. But we still had some medical challenges, and I just want to go through a couple of those now. So the first thing that I was trying to prepare for is how are we going to manage infectious disease in a post-COVID era? People had really got fatigue. I think probably only the people in this room and doctors are the people testing for COVID these days. And just to set the context, so an Olympic Village is the closest analogy I can think of is like the Gosford Caravan Park on steroids. You've got 15,000 athletes and officials all living on top of each other, and there's action all day round, 24 hours a day. And we share dining, you share bedrooms, you share bathrooms. So if ever you were trying to think of an environment that would encourage spread of disease, this is it. The other thing about the Olympics is that even mild infectious illnesses can really impact performance. And it can really derail people's Olympic experience. So we needed to try and account for that. There are a number of lessons from Tokyo though, and that is we had a significant reduction in infections between Rio and Tokyo. Not surprisingly, there was a 90% reduction of presentations of infectious illness in Tokyo versus Rio. And it just showed us what we already knew really, that simple interventions work. So masking, physical distancing, hand sanitising. So what we wanted to do, we didn't want to go back to the bad old days of Rio. We wanted to maintain some of this, but without losing the total Olympic experience. So in terms of our planning pre-Paris, I'm not sure, my photos aren't coming up there for some reason. We did a number of things to plan for the Paris Olympics. One of them was just educating our stakeholders, which was our athletes and our officials, just to give them a context for why it was important that we reduce the spread of infectious disease, namely impact on performance, because that's the thing that really spoke to them more than health. So we did a lot around that, and we planned our infrastructure. The photo's not really coming up, but we couldn't plan obviously the Olympic Village, but what we could plan is our own Australian compound, and we did that by we found the most sort of populous site in our Olympic Village was the coffee cart. And so we set our coffee cart, our barista outside. We also put our tables and chairs outside so that we could dine outside of the main Olympic Village and have our settings there. In terms of, I'm not sure if any of those are going to come up, but anyway, in terms of our isolation and accommodation procedures, we also really worked that out in advance because Olympic villages are very tight in terms of space. There's very little, there's few single rooms, there's very little rooms for isolation. So we secured accommodation off-site, but we also set up what was quite an interesting social experiment in a way, and I think, I'm not telling you anything that hasn't been in the papers, but our women's water polo team came in with a few cases of COVID. So we set up a COVID apartment, and then we had an RSV apartment, we had a mycoplasma apartment, we had an influenza apartment. And it was a very interesting social experiment because it was the first time really that athletes from different teams were actually mixing together in the apartments. But also it took the pressure off the doctors in a way, because what we found is people that were 5 days into their illness were advising their fellow athletes who are only 2 days into their illness about what sort of symptoms they could expect, what treatments worked for them, and when they might expect to feel a bit better. So it was a very interesting scene. Now that's just, this is our barista obviously, and these are our outdoor tests. This was Tokyo, where you can see everyone was highly masked. The other thing that we introduced in Paris was this 48-hour rule. So for the first time, and it was met with various popularity amongst the athletes, but for the first time we made athletes leave the village 48 hours after the competition ended. And the reason for doing that is we'd noted at previous Olympics that the second week athletes were really disadvantaged, one because of partying in the village, but secondly because those that had partied often came back with infections. And so we were committed to creating an equal high performance environment in the second week as we were in the first week. And so we got them to move out 48 hours after competition, which worked well. And the real game changer, I think, was point of care PCR testing. So we had 2 BioFire machines there, which are, as you can see, are fairly small and transportable. And we could do a respiratory panel within 45 minutes and test for 22 pathogens, similarly with a gastro panel that took an hour. I was concerned that people wouldn't present for swabs because in the post-COVID environment, people don't want to be swabbed. But in fact, we brought the athletes along the route with us and said, you know, it may give us the potential for early intervention. And basically, people like to know what they've got, particularly if they're about to compete in an event of their life. They don't want to hear they've got the common cold. They want to know they've got rhinovirus and this is how long it's going to take, or they haven't got something. So even just for reassurance reasons, it was very useful. And as I said, it was easy to operate and transport, and everyone in the medical centre learned how to use the machine, and we could even do them in the middle of the night. The other thing that contributed to a lot of people presenting for swabs was it was a bit of pressure from teammates as well. If you were in the coffee cart and you sneezed more than once, someone would tap you on the shoulder, take you outside and say, mate, you need to get a swab. So there was a lot of peer pressure to get tested. So just in terms of our PCR results, so in the context, we had an Olympic team, we had 470 athletes, and our whole team was about 1,100 people. But having said that, only about 2/3 of them were in the village. So we're looking, the denominator's about 700. So we did 102 tests over the 3-week period of the Olympic Games, of which 54, nearly half were, or a bit more than half were positive, and 38 in athletes. The respiratory pathogens, we saw just the usual community ones, but what was interesting is that COVID predominated, as one would expect given the knowledge of how it's transmitted. We had, I'd say our sickest people were those that had influenza, despite early use of Tamiflu. They were 4 officials, and in fact 2 of them were medical personnel who had assisted in a cardiac arrest 3 days prior in the village. And so we had a spattering of other ones as well. And then we had an interesting collection of gastrointestinal pathogens as well. Now, this I'd just say, don't take a picture because I haven't shared this information with anyone. And also, I'm not sure how it would be interpreted outside this room. I'm not even sure how to interpret it myself, but I thought as an interesting exercise on my charter flight home, I'd try and look at who had COVID and who got medals. So we had 26 cases of COVID, of whom 20 were in athletes. And then 15 of the 20 I said were during competition because they had their first symptoms or their positive test within 7 days of when they competed. And what was amazing to me is that 13 of the 15 won medals. Now, some of them obviously are in team sports, but it's still pretty interesting statistics. And that's why I didn't want it shared, because I don't want people to think that COVID is performance enhancing. But it led me to try and think about a few things. I mean, one is, I suppose, that COVID's a much less severe illness now than it used to be. And we've got a highly vaccinated young athletic population. They all had to be vaccinated before Tokyo. And the other thing is they've been exposed multiple times, so I think that's part of it. We didn't quite move away from total COVID exceptionalism though, because we are mindful of the fact that it spreads more easily, so we still wanted to take account into that. And we did that by any official that had COVID, we moved them off site, and any of the athletes that had COVID, we were very strict about the isolation procedures because we didn't want it to spread amongst the team. So we haven't quite moved on from COVID exceptionalism, even though they are able to compete. The next infectious disease I wanted to talk about was the waterborne infections, and that was also interesting, and you might have read a bit about this, about swimming in the Seine. But there's a very good reason why Parisians don't swim in the Seine. It's very dirty, and they haven't swum there since 1923. And the reason for that is when you have big rainfall, what happens is you get untreated waste and sewage that just goes directly into the river. The French government committed to spending a lot of money, in the order of 2.2 billion Australian dollars, to clean up the river for the Olympic Games, but also purportedly to allow recreational swimming in the Seine after the Olympic Games, which I'm not sure has happened actually. But there was a lot of fanfare, and in fact 2 weeks before the opening ceremony, the French sports minister and the gold medalist from the Tokyo Paralympic triathlon both went for a dip. They only went for about a 5-minute dip, and bearing in mind that our marathon swimmers were going to be in the Seine for 2 hours. We're actually not immune to contaminated water. We'd experienced it before in Rio, where this was the water off Guanabara Bay, which is where our marathon swim was in Rio. And here, this one's an interesting one. This is just off the waters of Rio too, with our highly sort of expensive graphite delicate sailing boats, and there is a dead dog right next to the boat there. Probably not a good thing to hit in your graphite boat. So we'd prepared for contaminated water in the past, but what was different was the water quality requirements had significantly changed between Rio and Paris, and World Triathlon and World Aquatics had set limits for E. coli and enterococci. To give you some context, our triathletes, they had to compete in their individual event, and then 4 days later they were all competing in a teams event. So we wanted to make sure that they stayed healthy between those 2 events. Our marathon swimmers were 2 hours in the water, but they needed to swim in the Seine before their competition because the currents are very strong, and they wanted to work out their race strategy. So again, we wanted to make sure that they didn't get sick between their training run and their event. And this is just to show you, this is on the left is E. coli and on the right is enterococci, but you can see the huge variation in water quality from day to day really, mainly related to rain, but often there were factors that we couldn't understand. And if you look, this is where the limits were down here. So there were very few days in which they could actually compete, and they were very lucky in a way, the organising committee. The men's triathlon was deferred for a day, but all other events occurred on those very few days where they were down below the levels, which we were very grateful for. So again, when I get a tricky situation, I contact my experts, and this was Joe Teresi at the Doherty Institute was my advisor here. And we tried to work out a prophylactic regime that we could give our athletes that wouldn't impact their performance but would help reduce the risk of infection. So we gave them Duke oral vaccine, a anti-cholera vaccine, which has some efficacy against E. coli. We gave 2 doses of that to them a month out from competition. And then we gave them rifaximin, which is an antibiotic I'd never used before, but I understand it's used in end-stage liver failure. But it had a lot of advantages. It was good against gram-negatives. It was non-absorbable, so it was very good for the gut, and also with a low side effect profile. So we gave that to them on the first day of their exposure and then for 3 days after. And then just irrigation, essentially, and antibacterial skin washes. And we offered them early PCR if required. Interestingly, worldwide, they have their own prophylactic regime in marathon swimming, and that is they down a bottle of Coke straight after the event, and that's what they attribute their lack of infections to. So we don't know if it was our wonderfully thought out prophylactic regime, if it was the Coke, or if it was just good luck. But none of our athletes got sick, and a lot of other athletes, international athletes, did. So it was good from our perspective. So just some takeaways. So I think, as we described, major sport events are ideal settings for spread of infectious disease. We've recognised that at the Australian Open for a number of years, and as Lou was reminding me, we started our on-site PCR testing at the Australian Open before COVID, just because we had 1,000 tennis players arriving in Melbourne from the Northern Hemisphere predominantly with all their infectious diseases. So it's a perfect environment for spread. We know that even mild infections can impair performance, and so we want to try and minimise them as much as possible. Point-of-care PCR testing can be a very valuable resource, and we found it to be both at the Australian Open and in Paris. And the most effective measures we found for minimising the impact of infectious disease at major sporting events was pre-planning, so planning our infrastructure so that it was purpose-built. Educating our stakeholders, bringing them along the way so that it wasn't us imposing things on them. We had to point out to them what the benefits for them would be. And then finally, prompt isolation and identification of cases using PCR. Thank you.
Thanks very much. Really interesting talk there. We've got time for maybe 1 or 2 questions from the audience. If I can just remind you to introduce yourself and where you're from when we ask a question. Maybe we'll start down the front or down there. Yeah.
Thank you very much. I'm Bronwyn King. I'm about to speak, so sorry to hog the airwaves. I just wanted to ask, did all those 20 athletes who got COVID in Paris get access to Paxlovid?
They were all offered, Paxlovid, yeah.
But some didn't want to take it? They were nervous about the impact?
No, they did. Most of them did. And again, there's ethical issues, I'm sure, that in the room about the use of Paxlovid in young, healthy athletes. But this is a high-performance environment. It's their only chance at an Olympic Games, and so most of them took it up.
That was my question, but was there a difference between those that took it and those that didn't?
If I'm to be brutally honest, 100% of them took it.
Before the Tokyo Olympics, the first time it was planned, we visited Japan and suggested they should have meningococcal vaccines to stop the spread of it. So my question is, it was taken up by the military colleges, but it wasn't taken up as a general prevention. Any comments about where men B particularly, or meningitis vaccines in that age group?
Yeah, I mean, obviously in Tokyo we mandated what vaccines the COVID vaccine and influenza vaccine, but in Paris we didn't mandate any vaccines, but we strongly recommended, our language changed somewhat, strongly recommended all the childhood vaccines, seasonal influenza, and that they were up to date with their COVID vaccines. In Paris it wasn't probably such an issue, I don't know, in terms of the meningococcal, but we didn't mandate it, no.
I just imagine that this group might be one that might be susceptible to long COVID, and just wondering if that's been picked up in athletes.
Yeah, from our Paris athletes, I don't know. I bid them farewell when the charter arrived in the hangar in Sydney, so I haven't necessarily followed them up there. Certainly a number of all of our athletes essentially had COVID in the past. I haven't got stats on that, yeah.
So my name's James Smith, I'm a public health physician in Brisbane, and I guess some of us from Queensland are looking forward to 2032 and thinking about our surveillance systems. One of the key things that we've found with point of care testing has been the kind of the lack of transfer of information from PCR machines through to public health networks and things. Is there the facility for you to share that information with perhaps a group of medical directors or with Olympic officials, or how does that, the results of the PCR testing get spread?
That's a very good question, actually. And so there were 8 National Olympic Committees in the Paris village that had BioFire PCR machines. So we have shared that data and we will publish that data. In terms of, say for instance at the Australian Open, we had a norovirus outbreak in our childcare centre. We have a lot of our players travel with their children now. And so, notifiable illnesses, we go through the channels and we notified Victorian Government. We did the, necessary infection control measures based on that. So we are still communicating with public health authorities on the basis of that. Yeah.
At the Commonwealth Games on the Gold Coast, we had a mumps outbreaks in the Games Village that actually started in Auckland and then went through them. I mean, I ended up clearing the New Zealand Rugby Sevens to play, and they then defeated Australia in the gold medal game. Should we pay more attention to the potential implications of letting these people go on in the game?
Exactly.
And I might just finish with one online question. So do you have any immunocompromised athletes, and how do you prep them for sports or the Olympics and manage their journey with respect to infectious diseases?
Yeah, we do, and not just, obviously in Paralympics we have more, but in the Olympics too we have immunocompromised athletes, and we aim not to be the total service provider. We aim for them to go back to their specialist physicians and get advice regarding that, so we don't do anything differently, we just rely on their advice.
Great, thank you. Join with me in thanking Carolyn Broderick again for a fantastic talk.